to the active metabolite in the liver. Both compounds are present in the plasma, and then there's a mechanism of detoxification through glucuronidation, for which two enzymes are really important, the UPGT and UGT1A1. In particular, for the latter, there's a polymorphism, and in case of UGT1A1 to 8 polymorphism, there's a reduced elimination because the glucuronidation is variable and it's decreased. And this could be one of the reasons of the diarrhea caused by CPT11. So in case
Cristiana, Cristiana, does this UGT polymorphism have any clinical relevance, or are there clinics who are screening patients for that?
Yeah, do you want to comment on that? Because this is really an important point and frequently asked question.
Yeah, so there is a bunch of literature showing that patients with polymorphism, dysfunctional polymorphisms, have more, in particular, mononeutropenia, mononeutropenic fever. But as far as I know, there is, if any, then there is very few clinics who are screening patients, at least at the moment.
Right. And are you screening your patients for the polymorphism? You are screening the patients? No. You don't screen the patients. And perhaps you want to comment also on another important point, the point of the Gilbert syndrome for CPT11. So the point is that patients with the Gilbert syndrome can have a higher toxicity, which might be related also to some enzymatic mechanism. So in general, one of the caveats is to be careful with those patients. But I think the point of the UGT A1 to 8 is very important because, many times we are offered to screen routinely for the polymorphism, but we are not doing because there are not so many clinical data, and anyway, it's not so frequent. So it depends very much also on the number of patients you're treating with CPT11.
Right.
The point is that if you have some hepatic dysfunction, you should be careful because there's a higher risk of toxicity, as Marcus said, myelotoxicity, but also diarrhea. And also there's a higher toxicity in case of pharmacogenetic variation, which is exactly what Marcus mentioned. Okay, so this is the point of the diarrhea, and this is really clinically important because you should learn how to deal in a safe way with CPT11. So, as you know, there are two different types of diarrhea. There's an acute one, which usually appears within 24 hours from dosing, and that's related to an increased secretion of cholinergic compounds, and there's an increased cholinergic secretion. And the clinical signs are abdominal cramps very early, so the patients start complaining of abdominal pain, they start sweating, they have lacrimation, and the diarrhea could be really a watery diarrhea. So you should stop the infusion and you should immediately start putting fluids in. So it's really important to have always a line, and perhaps during the first administration, keep the patients for, I would say, 2 hours after the first administration to see how it's tolerated, keeping in mind that it could appear also after the second or the third administration. And then the drug which should be given is atropine because of the cause, which should be given subcutaneously or IV, and these are the recommended dose from 0.25 to 1 milligram. And this is dose dependent. So if you have a patient with a hepatic dysfunction with a higher risk of toxicity, be careful because the acute diarrhea might be one of the symptoms which appeared. But then you have the late diarrhea. which appears after 24 hours. It could be the week after you have seen the patient. So the patient should be informed, and you should tell the patient that in case of diarrhea, when he or she is at home, they should call you immediately, because at this point you can have also other toxicities, which could be myotoxicity, neutropenia, neutropenic fever, and since you have a damage to the intestinal mucosa and you have a low neutrophils, you have a higher risk of infection, and they should be quite severe infection because you have an open wound in the luminal wall, and through this wall, everything could go in, and the patient is exposed to severe infection. So again, the patient should go back to the hospital. They should be properly hydrated. It's a watery diarrhea again. And then they should start loperamide. If they have also nausea and vomiting, you should hydrate the patients and control if they can take the drug. It's 4 milligrams as a first dose, and then it should be given from 2 to 4 milligrams every 2 to 4 hours until recovery. So this means 2 pills at the first episode, and then you should repeat, usually I give 1 pill until recovery, and you should continue the treatment until you have at least 24 hours without diarrhea. So the point is that you give the first pill, and then if you have another episode, you give another pill, and then you give the treatment once you have again diarrhea. Otherwise, you wait and keep the hydration and try to control as well the nausea and vomiting in case they are present. If you don't have the control of the diarrhea with loperamide, or perhaps the patient has a severe nausea and vomiting, loperamide cannot be given, you should start with octreotide, 100 or 150, 3 times a day, subcutaneously or IV. But it's important to keep the patient in hospital dehydrated and check the hematological counts. Who are the patients at higher risk? The elderly patients, the patients with Gilbert syndrome, the low performance status, or the previous bowel radiotherapy, because the mucosa has been already damaged. And it's not dose dependent. That in case you have patients with Gilbert syndrome, hepatic dysfunction, start with a lower dose. Can I get the next slide? So these are the characteristics. These are the dose which is recommended. It's 90 minutes infusion from 300 to 350. That I put a lower dose if there's a Gilbert syndrome, 200, 225 if you have an abnormal liver function. So start low, and then you can increase later on. These are the characteristics of the metabolism I told you, and these are the characteristics of the pharmacokinetics. So the active metabolite has a longer half-life, which might be relevant to expect in some way the toxicity. This is for topotecan. Topotecan is given IV as a shorter infusion, usually is given daily times 5 every 3 weeks. Because of the myelotoxicity, we don't use the weekly dose. The weekly dose was used in ovarian cancer in a trial which is debatable. It's easier to use, but it's cumbersome for the patients. And if you want to adapt the dose, you can decide to use a lower dose, or you can decide to give the drug for 4 days instead of 5. When the dose is to be decreased, what is different from topotecan and irinotecan is that while the metabolism of CPT11 is mostly in the liver, the excretion, and the excretion is in the liver, the excretion of topotecan is through the kidney. So the point is that you have to decrease the dose in case you have a creatinine clearance less than 60. The metabolism is the same, and what is the problem for topotecan is that the PK is quite variable. Usually the half-life is between 2 and 3 hours, and the active metabolite, the desmethyl, has a longer half-life. So keep in mind that the excretion is different. This is the important point, and how to adapt the dose. Can I get the next slide? Yes, so the point is that ask questions because we want to make you comfortable with the use of this compound. I wanted to add one consideration on the use of oral topotecan, which is something which is still sometimes used, for example, in small cell carcinoma and so on. I think it's difficult to use, it's not recommended, and if you want to use it in a small cell carcinoma, where it could be given a second line, it's important to give IV so that you're sure that the drug is in. Then let's move to the TOP2 enzymes and the inhibitors. So the mechanism more or less is the same. We have two different isoforms of the TOP2, the TOP2 alpha and the TOP2 beta, and the active compounds are effective against the topo alpha isoform. We have two different classes, the epipodophylotoxin, and they are selective alpha inhibitors, and they produce stabilization of the cleavable complex and produce a double-strand break. So it's comparable to what happens with the topo-1 inhibitors. And the other important class are the anthracyclines, and they are topo-2 inhibitors because they intercalate in the DNA. So the site of action in some way is different. One is an inhibitor and the other ones are intercalators. But anyway, the result at the end is the same. So the point is that we know that there's a very often resistance to topo-2 inhibitors, and this could be due to a mutation of the gene, or it could be due to a decrease of the topo-2 expression, or it could be due to the overexpression of paraglycoprotein, which is a drug transporter, and which is also related to the multi-drug resistance. This is very relevant for anthracyclines. Let's go to the next slide. These are the epipodophylotoxins. You can see that the structure is completely different. Their main toxicity are the myelotoxicity, the nose and vomiting, and the alopecia. When we use high doses, for example, etoposide for the treatment of lymphoma, the dose-limiting toxicity becomes mucositis. So it's important to keep in mind for the clinical use. Next slide, please. Okay, so these are the characteristics of the etoposide. Etoposide has a linear PK when it's given IV, with a half-life between 4 and 11 hours. It's given once a day. The excretion is in the feces and more in the urine. It's highly protein-bound. The metabolism is through a conjugation, and the dose should be decreased in case of a creatinine clearance less than 50. There's no need to modify the dose if we have a mild hepatic dysfunction, because the main excretion is through the kidney. So let's look at the toxicity. This is important from the clinical management, but also in terms of combination with other chemotherapeutic agents. We expect the neutropenia between 5 days after treatment up to 15 days. Usually is between day 8 and 12. So it's really important to have a control of the hematology during those days. The nausea and vomiting is more than 40%, so it's necessary a pre-medication. Diarrhea is not so frequent, but we have alopecia, which is complete after repeated administration in more than 60% of the patient. Now, there's really an important thing to keep in mind because we know that etoposide is used in testis and germ cell cancers, which are curable disease. And we have today long-term survivors. Sometimes there's a recurrence of this disease. We have to reintroduce etoposide. So remember that there's an increased risk of secondary leukemia and myelodysplastic syndrome, mostly secondary leukemia, if we have a cumulative dose higher than 2,000 milligrams per square meter. And if you keep in mind that we give around 500 milligrams per cycle, because we give, like here, etoposide, the dose could be between 60 and 120 for daily times 5, which means that with 120 we have already 600. If we give 3 cycles, which is the recommended treatment in germ cells, or perhaps a 4 cycle in case of metastatic disease in testicular cancer, we are at 2,000. So the point is that if the patients had a recurrence of, if there's a need to reintroduce the treatment, remember that there's this increased risk of leukemia. And the median time to appearance is around 3 years, but it could appear also later on. There have been cases of a long-term survivor of testicular cancer who developed secondary leukemia more than 10 years after the treatment. Then, these are the recommended dose. Remember that if etoposide is given orally, which was frequently used as palliative treatment in small cell or, for example, in ovarian cancer, the pharmacokinetics is very variable because the absorption is very variable. So there are patients who absorbed about 80%, patients who absorbed less than 50%. And since the drug is given almost chronically for 2 weeks or 10 days, there's a risk of accumulation. And since these patients have been very often pretreated or had some brain radiotherapy, they have a definitely higher risk of severe myelotoxicity. So it could be completely the opposite of the aim with which was given the oral administration. So could be not really a safe, manageable treatment, but quite a difficult and potentially toxic treatment. So remember and evaluate always properly the patients and the kidney function. Then today we use the etoposide phosphate. It's simply a phosphorylated form which was done in order to decrease the incidence of the hypersensitivity reaction which was initially observed with the old formulation. So this allowed to give the treatment over a shorter period of time. Initially, we were giving etoposide infusion over 3-4 hours. Today, with the etoposide phosphate could be given from 5 minutes up to 2 hours. And also, it's feasible for the high dose administration. And usually for the high dose, the recommended dose is 1,000 milligrams over 24-hour infusion on day 1 and day 2, which is a treatment which clearly can be given only once, because we are already at the dose of 2,000 milligrams per meter square.
Cristiana, you mentioned that topotecan as well as etoposide can be given orally. We do this sometimes with, in particular, I know that from small cell lung cancer patients, sometimes we think it's more convenient to patients. So what would your main concerns be? Would it be the high variability of absorption or rather compliance issues? Because if I understand you correctly, you prefer the IV administration.
I mean, it depends very much on the aim of the treatment. When it's given with a potentially curative intent, it should be done IV. So, for example, if there's let me say, small cell lung cancer patients who achieved a very good response to the first treatment, relapsed after a longer period of time, and you have a high chance of getting again a good response, and perhaps you decide you want to give some treatment with carboplatin and VP16. And perhaps you don't want to ask the patients to come back for 5 days because carboplatin is given only on day 1, and then you say, okay, you can get the other days of etoposide orally. I prefer to ask the patient to come back and try to squeeze the administration over 3 days by giving a higher dose than giving it by 5 days, but I prefer to give it IV. Then, if there's elderly patients with a small cell who had an earlier relapse, but there are symptoms, and you think you can have a good chance to get some symptom controls by an easy treatment, perhaps what you can do is that you can give the treatment, perhaps you want to give 75 instead of 100, which means that you can give one day 1 capsules and the other day 2 capsules, which means a daily dose of 75, and then perhaps you can give the treatment for 1 week, and then you can ask the patients to come back after 1 week to check the exams, to look at the mouth, to see if the mucosa is fine, if there are no any mycosis, and then you can decide if you want to continue the treatment and how long. Perhaps you want to give it for 10 days instead of 14, because you have seen some initial stomatitis, and that would be fine. And then if everything is well tolerated at the subsequent treatment, which can be started, for example, 10 days after 14 days, you can give 14 days instead of 10. So something like that. The advantage of the capsules is that you can play with the treatment and you can adapt the dose and the duration of the treatment. This is my suggestion. Then it's very much on the clinical situation. Are there comments on that? Marcus, what do you think?
No, I fully agree. I do not see any comments. So if there are comments, I would interrupt you.
Yeah, then thank you very much, because it was an important question. So if we want to move on to the subsequent slide. So let's go to the anthracyclines. I apologize because there are some Italian names, but I think anyway you can easily recognize the compound. It's doxorubicin, daunorubicin, epiadriamycin, and idarubicin. So these are, there's plenty of analogs. There's been a lot of work done on the parent compound, which is doxorubicin, and I think that my opinion is that for solid tumors, doxorubicin is one of the most important chemotherapeutic agents, and there's not proven benefit of epiadriamycin over adriamycin of doxorubicin. Why idarubicin is used only in acute myeloid leukemia. There's no place for using idarubicin in solid tumors. So this is the structure. We have the sugar, which is linked to the I-glycan, and basically the I-glycan is responsible also a part of the cardiotoxicity. So let's go to the next slide. So they are TOPO2 inhibitors. They act through DNA intercalation, and produce an inhibition of the transcription and the helicase enzyme. And this is the mechanism which is important for the cardiotoxicity because of reduction processes, that the production of reactive oxygen species, the ROS one, the free radicals, and they interact with macromolecules like DNA or with the lipid membranes. They produce a damage, and these are the mechanisms responsible of the cardiotoxicity. So one of the fields of investigation was to decrease to have a scavenger system to get rid of this loss of the reactive oxygen species. And one of the main mechanisms of resistance to anthracycline is the overexpression of the PGP or the multi-drug transport protein, which are responsible of the increased efflux of the drug from the cells. And there has been a huge field of investigation on PGP inhibitors and also how to combine doxorubicin with PGP inhibitors. But I think that overall, from the clinical point of view, this field of investigation hasn't been successful. So I don't think that there are still clinical studies or clinical practice ongoing with this kind of combination. I don't know, Marcus, which is your impression on that?
No, I fully agree. Some 10 to 15 years ago, this was a huge field, as you mentioned, but unfortunately not successful.
Yeah. Also, due to the fact that it was difficult to do it, it was difficult to prove it, and there were new compounds coming up. So, 15 years ago, anthracycline and platinum and so on, they were some of the few chemotherapeutic agents available. Today, it's a completely different scenario. So it was decided, and it was a good decision to invest on new drugs. Let's move to the next slide. Okay, this is the pharmacokinetics. What is important is that the main derivatives have a similar property. They have a triphasic plasma distribution and elimination. The half-life alpha is related to the tissue uptake, and this is the one which might be responsible for the cardiotoxicity, the uptake in the liver, and this is why, as a potential way to decrease the cardiotoxicity, there's the use of weekly treatment or prolonged infusion. Then we have the beta half-life, which is related to the hepatic metabolism with the production of the active metabolites as well as the toxic compound, but the alcohol compound, the active doxorubicin, is the most active compound. And the mechanism of through the agglicons with the conjugation for the detoxification. And then this is the gamma half-life, and in case of delayed elimination, which is mostly related with the decreased hepatic function, we can have a toxicity which is myelotoxicities plus stomatitis, which are the characteristics of anthracycline. And these are the indication on how to reduce the dose. Keep in mind that for other drugs, the main parameters to look at is bilirubin. So the dose should be adapted quite substantially according to the value of bilirubin. Don't look at the transaminase or alkaline phosphatase. What is really relevant is the conjugation, and therefore the bilirubin is the most important one, which is related to the cholestasis, or when the mechanism of glucuronidation doesn't work properly. So if we move to the next slide. So if you have questions as regards topo 2 inhibitors and their characteristics from the pharmacological PK and mechanism of action, please ask it. And then we move to the clinical use. So these are the three important compounds. Doxorubicin, it's used in soft tissue sarcoma. This is really an important indication still today. Thyroid anaplastic carcinoma, breast, and anthracyclines are really important for the management of breast cancer and non-Hodgkin lymphoma in the BVD schedule. And these are the doses. So keep in mind that it's important not to underdose adriamycin. Don't be afraid to use it at the full dose because this is the right dose. You cannot give adriamycin for a prolonged period of time. You know, it's not feasible to give too many cycles of treatment. So it's important to give full dose because it's really a dose-dependent, steep dose-dependent response. So the recommended dose is from 60 to 75, 60 for combination, 75 for single agent, 20 milligrams per square meter per week if you want to use a weekly dose. And the weekly regimen is given continuously, or at least you should give at least 6 administration, and perhaps you can have 2 weekly dose. But the point is that, again, with the weekly schedule, you can tailor the dose. So you can give one treatment, and then you see the patient after 1 week. And if the mouth is fine, you can give another treatment. Try to give the treatment at least for 4 weeks. And then you can have a pause if you see that leukocytes are slowly decreasing or there's some increase of stomatitis, or otherwise you give it for 6 weeks. If you are giving for a curative intent, this is really important. The indication for epirubicin is the same. You can see that you can give potentially higher doses, but the potency, you know, the point is that this is corresponded to the dose of doxorubicin. So there's no really an advantage of giving epirubicin over doxorubicin. Initially, it was produced with the idea that it was less cardiotoxic. But the point is that if you give a full dose of doxy and if you give a full dose of epirubicin, eventually the cardiotoxicity is the same. You can give a higher cumulative dose, but the point is that you should give a higher single dose. So overall, the number of cycles is the same, and the parental compound is the same. And the combination is between 60 and 100. For idarubicin is given for 3 days in combination with Ara-C, 12 daily for 3 days. Can I get the next slide, please? So these are the toxicities. The toxicities are common, and they are dose-dependent. So it's really important to look at the time of appearance. Neutropenia appears between day 10 and day 14. The maximum is usually on day 14. But if you see already some neutropenia on day 10, be careful because the neutrophils are going to go down further. So be ready to, to potential problems. And it should recover in 2 or 3 weeks. So it's really important to give anthracycline every 2 weeks to be on time. The mucositis is maximum after 1 week. So I recommend to see the patients after the first dose 1 week after treatment. And there's the need of prophylaxis. So you should inform the patients that the teeth should be brushed after eating. There could be a rinse of the mouth with chamomile, but it's really important to keep in a good hygiene of the mouth. And if there are problems in the mouth before starting, send the patient to a dentist to try to evaluate the situation. Nausea and vomiting, it's a highly metagenic compound, so it's really important to have a good prophylaxis, which should be prolonged, because nausea and vomiting could be delayed up to 48 hours. And if patients have a bad experience with the first administration, they are always scared and they are more prone to develop toxicity after the subsequent administration. Alopecia is early and complete, so inform the patients. I usually recommend to cut all the hair and to have a wing if they want, or something, but they should be informed. Also inform the patients that there should be a hyperpigmentation of the skin and the nail, because if they don't tell it, then the patient will be scared because they see their nail, violet or with a strange color. It's important to cover the skin if they take sun, to put a cream, and to avoid direct sun, because they can develop spots which are not nice on their skin. And also there should be a recall effect after radiotherapy, which means that if the patient had radiotherapy, for example, to the pelvis and or to the breast, and then they receive anthracycline also after 1 year, there could be some hyperpigmentation, a reddish of the skin, and the patient could be scared if they haven't been informed. There could be a local toxicity, which is phlebitis, pain in the vessels, or a thrombosis, so that the nurses know where they can inject anthracyclines in safe vessels, not too small, not on the cover of the hands, and not in the elbow, for example. But also the point is that there can be an extravasation, and there should be, procedures in-house how to manage the extravasation. Remember that if the extravasation is severe, there can be a very deep ulceration, and there can be of the fibrosis during the healing of the soft tissue with impairment of the mobility. And then there could be some hypersensitivity reaction. The hypersensitivity could be local. There could be some reddening of the vessels, but there could be also some systemic hypersensitivity. And if the patient had already some hypersensitivity to some other drugs, for example, you can have a slower infusion at the beginning to check the tolerability. And then anyway, if you have a good antiemetic prophylaxis, usually you should have steroids, which is another way to prevent the hypersensitivity reaction.
Cristiana, do you do baseline ultrasound of the heart in all patients before starting anthracyclines?
Sorry, ultrasound of what?
Do you do an ultrasound of the heart in all patients before starting anthracyclines?
Well, we usually do, yes, echocardiogram. Yes. Before starting, yes, because, for example, if we give it for breast cancer, and we should give at least 4 cycles of treatment in combination with cyclophosphamide, and perhaps the patients have also some breast irradiation. We want to show which is the baseline function, because then in case of clinical symptoms of some cardiac impairment, you don't know if it was something which was already present but was of a lower degree because you didn't screen it, or if it's something new, which in this case might be definitely ascribed to anthracyclines. And at this point, you should decide whether you want to continue the treatment or not. So we perform it. We do echocardiogram, yes. So that's in terms of cardiotoxicity, this is the definition. The classical definition is a decrease of the left ventricular ejection fraction more than 10% from the baseline, with the absolute value of less than 50% of the ejection fraction. And this is related to a damage to the myocytes, usually have a late onset, and it's a chronic, so there's a further worsening. So you can have an acute cardiotoxicity with some rhythm disturbances, which is reversible, and then you have really the scaring one, which is the late onset chronic, and it could be also non-reversible. And there's a progressive cardiomyopathy with complete damage of the myocytes, which is concentration dependent, and it's what I mentioned of the rapid administration and as a potential cause the high heart uptake, which is due to the oxidized radical production, which can appear also 20 years later. And if you remember the story of the awareness of the cardiotoxicity of anthracycline was that in children who were cured from lymphatic leukemia, acute leukemia when they were children with Doxorubicin, they developed cardiomyopathy when they were 14, 15, at the time of the development of all the organs. And at that point, the cardiomyopathy was already there and was irreversible. And actually, the cardiotoxicity of Doxorubicin is higher. But the point is that at that time, we didn't know that there was this potentiality, and we are perfectly aware today. So we know that it's related to the cumulative dose which has been given, and these are the doses which are associated with a higher risk of cardiotoxicity as single agent or in combination. And we know also which are the risk factors which are a mediastinal radiotherapy. For example, in Hodgkin disease, Hodgkin patients have a BVD and then they need some radiotherapy. There's a higher risk of cardiotoxicity, and also the age, and also the pre-existing heart disease with some impairment already of the cardiac function. Okay, so this is the management. It's important to have a regular assessment of the cardiac function by echocardiograms, and this is the recommended treatment, which is the angiotensin converting enzyme as a first line, and then in case they are not tolerated, beta blockers. And the prevention is by the use of weekly administration with lower single doses or prolonged infusion, as it was done, for example, in soft tissue sarcoma in the past. And there was the development of cardioprotective agents like the iron chelators, but again there were, that's really divergent clinical results. It was very expensive, difficult to use. So the point is that there was an active field of investigation with the development of a new formulation. I don't know, Marcus, if you have comment on that, on the cardiotoxicity of anthracyclines, and what are you doing in your practice?
Yeah, we are also doing baseline echocardiographies. We don't use Doxorubicin. I think in the US some colleagues use it, but I think in Europe not.
Yeah.
It's not very popular.
Yeah. And for elderly, for some palliative treatment in breast cancer, metastatic disease, in patients already pre-treatment, we use weekly Doxorubicin because it's easier to handle with. We use the cold cap only with the weekly administration because it might be useful and it's better tolerated in terms of stomatitis and nausea and vomiting. Then if we can move to the next is a calyx liposomal Doxorubicin, which is called calyx or Doxil according to the different countries. The main characteristics are the higher tumor uptake. It's higher in the tissue with the leaky capillaries as tumors, or in tissue with the macrophages, like tumor again, and in the liver. There's a delayed tissue release with the longer and higher exposures, and the toxicity is decreased because there's a higher selectivity because of the liposome characteristics and the reason I mentioned why there's a preferential tumor uptake. As you can see, the pharmacokinetics is different from the standard anthracyclines. There's a definitely longer beta half-life, and this explains the characteristics of the toxicity of the calyx. So the point is that the dose is 50 every 4 weeks. This is the recommended dose as a single agent. I know that it could be scary and worrying for some clinicians because of the potential higher risk of the PPE. The drug was registered for indication for breast with this dose, and the dose for the combination is lower. It's between 30 and 40 according to the time interval between retreatment. So if we go to the next slide. Okay, so this is the important point. The incidence of the hand-foot syndrome, which is the PPE, the palmoplantar erythrodysesthesia, is that there's an increase of the risk if you have a dose intensities greater than 10 milligrams per week. So the point is that keep the interval always of 4 weeks when you give the single dose at the dose of 50 or even 40. So if you give 50 for breast cancer, keep 4 weeks. And it's cumulative. So the point is that if after the first cycle you see some red, some erythema, mild erythema of the palms of the hands, or some initial mucositis, be aware that at the subsequent cycles you'll have an increase of the toxicity. So be careful. Everything should be recovered before retreating the patient. And if you see it already, you can decrease the dose. Otherwise, you won't be able to continue. And since it's given, for example, in ovarian cancer in combination, and you can have good results if it's given in platinum-sensitive patients, it's important to wait perhaps 1 week more, but to have a full recovery. Otherwise, you'll be in trouble. The patients will develop severe toxicity, which could be quite painful, and cannot be retreated. Perhaps treatment should be discontinued or cannot be treated for a long period of time. So the mucositis should be prevented. There are different ways of preventing locally in the mouth. I prefer to tell the patient to avoid to eat salted food or very picky. And also, you know perfectly well how to explain to avoid the problems in the hands and in the feet, avoid bringing very heavy weight during the first week after the treatment, keeping sun and so on. There could be some cutaneous rash because it's a photosensitizer and the sun exposure should be avoided. The nose and vomiting are really limited, and this is a big advantage over the doxorubicin. Alopecia is absent, and the cardiotoxicity is lower. The cumulative dose hasn't been defined. So if you continue for a long period of time because there's a good response and so on, the point is that you should monitor closely the left ventricular ejection function, as Marcus said, by echocardiogram, and you should start monitoring once you have a cumulative dose of more than 600, or when you have a cumulative dose of more than 450, if the patient had already doxorubicin. So, for example, you have a breast cancer patient. The patient had some adjuvant treatment with doxorubicin. Then there's the development of metastatic disease. when you want to calculate the cumulative dose already given, for example, of doxil, remember to add also the previous doxorubicin, because at this point the cumulative dose is definitely higher. Now, I don't know if there are questions, comments, and so on, and how much time is left. So
there is no questions at the moment.
Okay. So can we continue with the other parts, which are the tubulin active agents? And I want to briefly explain what is the mitotic spindle and the microtubule. So that's the mitotic spindle is a macromolecular structure, is all this one, to separate the sister chromosome during the mitosis. And you have the microtubules, which are called the spindle macrotubules, and overall they produce the mitotic spindle and the centrosome. So the point is that the centrosome is this particular part of the chromosome which allowed the chromosome to stick to the mitotic spindle and move along the mitotic spindle. And this is the part, the cytochore, which is a protein complex which is assembled on the centromeric region of the DNA. And this is the attachment point of the chromosome to the mitotic spindle. So these are the characteristics. And the microtubules are called astral when they are at this particular extremity of the mitotic spindle. Can we move to the next slide? And this is the movement of the chromosome along the mitotic spindle. The microtubules are polymers of alpha and beta tubulin, and they have a dynamic instability because they continuously assembled and disassembled. And they are important for the mitosis, for the intracellular transport, for the cytoskeleton, as also for the external mobility, which means the flagelli and the cilia, which keep clean different lumen, but also which allows the movement of the cells. And we have two main classes, the taxons and the Vinca alkaloids. The taxons, they promote the assembly into microtubules and inhibit the disease assembly. And therefore, the microtubule they are stuck. And it's not feasible to have the movement of the chromosome, while the Vinca alkaloids prevent the assembly of the microtubules. So the mechanism of action is on the mitotic spindle, but the result is quite different from between taxons and Vinca alkaloids. Can we move? Okay, these are the structures of the Vinca alkaloid. The most important one are the vincristine, the vinblastine, and the vinorelbine. And what is really fascinating is that how much the clinical activity can be different and some of the toxicity by changing in limited amount the radicals R1, R2, R3, R1, R2, and R3, which are attached to the vindolin nucleus. Next slide. And these are the pharmacokinetics. So there's the high intra and intervariability. There's a triphasic plasma disappearance, and all of them they have an important hepatic metabolism. And these are the half-life. As you can see, it's between 23 and 45, so it's really variable. Vindazine is not used any longer. It was a drug of which the clinical development was not really successful. It was tested in malignant melanoma, but today is completely discarded. Next slide. So these are the indications. As I told you, it's really, I think it's really incredible how much is different the clinical spectrum of activity. If we have vincristine, vincristine is important for the CHOP combination and also for the management of Hodgkin disease, for example, in the ABVD we mentioned before. But it's also important for the pediatric cancer, for children cancer, for example, in neuroblastoma, rhabdomyosarcoma, Wills tumor, for example, the VAC combination with vincristine, actinomycin, and cyclophosphamide, which is used also in case of persistent disease in germ cell in children or adolescents, or also in case of resistant disease in gestational trophoblastic choriocarcinoma. And when it's used in this combination with actinomycin, they are good combination with limited indication. They could be quite effective, but also very toxic. So it's important to know how to handle it. Vinblastine is used in testicular cancer, even though today in many regimens the first line includes epipodophylotoxin etoposide instead of vinblastine, but it's used for the management of recurrent disease. Vinorelbine IV non-small cell lung cancer, and vinorelbine orally in some breast cancer. We don't use that very often, oral vinorelbine. And vindazine is used sometimes in breast cancer, but it's a limited indication. Next slide. Now, the common toxicity, the most important one, in my opinion, is the peripheral neuropathy, which is very much important with vincristine. And is a peripheral neuropathy, sensory motor, does not really effective drug prevention, and sometimes is not reversible. It depends very much on the situation of the patient and the degree to which the neuropathy has already developed. So keep in mind that when you start seeing peripheral neuropathy, it could be also not so reversible, also in the long term. So you should decide when it's time to stop the treatment, even though it's effective, because the point is that it could be quite a troubling toxicity, because it could be a motor neuropathy, but also the sensory one. When you have an impairment of the fine movements, patients could be very much affected in their daily living. Vincristine could produce stomatitis, which is really troubling when it's used in combination, for example, a BVD, when you're dealing with potentially curable disease and you want to be on time with your treatment. The myelotoxicity is the main characteristic of vinblastine. It appears 1 week after the treatment, so patients should be checked 1 week after the treatment, for example, in the VIP combination in testicular cancer, and you should be careful, and you should be able to adapt the dose according to previous treatment. One of the worrying effects is the constipation. And when the vinblastine was used in combination with cisplatin, or it's still used today in combination with some testicular cancer treatment with cisplatin, the point is that very often you give as antiemetic 5-HT3 antagonists, which are constipating as well. So you have a kind of paralytic ileus. And in this situation, you should have, of course, preventive action, but also you should know what kind of laxatives you should use. Try to resolve this paralytic ileus, which could be very painful and troubling for the patient. Remember that they could be local vesicant in case of extravasation, and in case of vinorelbine, you have alopecia, so the patient should be informed. And also nausea and vomiting could be present with vinorelbine, so you need a prophylaxis. Next slide. So this is a summary of the toxicity I already told you. Remember the peripheral neuropathy, which is accumulative with vincristine, and also it's related to dose. The total dose cannot be higher than 2 milligrams. That's important, for example, in the different schedule of treatment for multiple myeloma in the VAD combination, and the dose should be decreased in case of decreased liver function. In case of imblasting, the dose-limiting toxicity is neutropenia, 1 week from doses with recovery in 2 weeks. Peripheral neuropathy could appear, but also remember the constipation I told you. These are the doses which can be given. So in pretreated patients, it's better to start with 4 milligrams because of the potential myelotoxicity, and it should be given every 7 or 10 days. And I told you already how to adapt those in case of decreased liver function. Next slide. And these are the toxicity of the vinorelbine. The dose-limiting toxicity is neutropenia. This is the recommended dose on the weekly treatment. And in case of oral neutropenia, remember the potentially higher nausea as well as diarrhea. So, the drug is given orally. The nausea and vomiting should be prevented also in order to take the drug in a proper way. And which are the risk factors for neurotoxicity? The age, definitely. The frequent administration. It depends if you give the treatment weekly or if you give the treatment every 10 days. But it's important to remember to give a higher dose, a dose higher than 2 milligrams, to achieve a cumulative dose higher than 5-6 milligrams. And also if you have a pre-existing neuropathy, like diabetes, or for example a previous neurotoxic treatment, cisplatin, carboplatin, taxanes, they are all risk factors. Also look at the baseline. In case it's difficult for you to evaluate the degree of pre-existing neurological impairment, ask for a neurological consultation. Ask for a neurologic exam so that you know exactly at which point you start, and then if you see a benefit of the treatment but perhaps some worsening, clinical worsening of the neuropathy, if you have a baseline, you can have a reassessment of the neurological function, and then you can discuss with the neurologist if you can continue or not. Also, if you have a poor nutritional status, for example, ephilic patients, they have a higher risk of developing neurotoxicity because of the, debilitation and the poor diet, and also the lack of vitamins, which might be important for the neurological function. Next slide. So if you have questions. And then the last point, the taxanes. You know it, paclitaxel, docetaxel, cabazitaxel, eribulin. I want to mention the nab-paclitaxel, which means that it's a paclitaxel protein bound, with the idea that the hypersensitivity reaction is decreased, but there's also a higher tumor uptake. Eribulin doesn't have the same mechanism of action of the taxanes, but it's usually included in this category. Next slide. So these are the characteristics of the pharmacokinetics of the different compounds. You can see that the half-life is different, that only cabazitaxel crosses the blood-brain barrier, and the hepatic metabolism is quite extensive for all the compounds, and these are the indication on how to decrease the dose. Remember that for eribulin, the dose should be decreased also in case of kidney impairment because of the relevance of the kidney excretion, and this is the indication how to decrease the dose in case of creatinine clearance between 30 and 50 milliliter. And these are the situations where a pre-medication is recommended with all of them but nab-paclitaxel for the reason I mentioned before. Next slide. Then this is the infusion time, shorter infusion time with nab-paclitaxel. These are the doses. So a higher dose is given because of the characteristics of the drug. This is the dose for the weekly administration. So 3-hour infusion for weekly paclitaxel. For docetaxel is 1 hour infusion. If you have some worry, a potential hypersensitivity reaction with docetaxel, or if you have seen some minor hints of potential hypersensitivity reaction after the first infusion, and the second infusion, perhaps you want to start more slowly, and then you can increase the speed of the infusion after the first 15-20 minutes if there isn't any appearance of hypersensitivity reaction. And this is the dose for the weekly treatment. For paclitaxel, the recommendation is to give weekly continuously, at least for 6-8 weeks, and then you can have some pause according to the tolerability. For the weekly docetaxel, you need a pause. There's a definitely higher fatigue, so the patients cannot tolerate more than 3-4 weeks of treatment before pausing. For cabazitaxel, the dose is definitely lower, and this is the treatment interval. Next slide. So these are the main toxicity. Remember that there are common toxicity, but also different toxicity. Alopecia is complete in almost all cases, but cabazitaxel. And the neutropenia is common, and it's higher with cabazitaxel. It's more myelotoxic than the other ones, and it's lower with nab-paclitaxel. The anemia is again more marked with cabazitaxel, and this is important. With docetaxel, you can have skin reaction, and this skin reaction, besides erythema like stripes, you can have skin nails toxicity. We are going to discuss it. Vomiting is not so extensive, and usually you have pre-medication, so the patient has also some prophylaxis. And you have the peripheral neuropathy. In brackets is the grade 3 peripheral neuropathy. It's very much cumulative. But also the risk factors are also those which we mentioned already for the vincristine. So there's about 10% of neurotoxicity with nab-paclitaxel, possibly also because of the higher dose which is given. And this is the asthenia is higher with docetaxel than with paclitaxel. And this is the problem of docetaxel, the fluid retention, which was seen at the beginning when it was given without the premedication, because you know that the excipients between docetaxel and paclitaxel is different. There's not the castor oil which is in paclitaxel, and this is the reason why docetaxel initially was given without the hypersensitivity reaction, the premedication against the hypersensitivity reaction. What was observed after repeated administration is that there was a fluid retention with some swollen of the hands, the appearance of edema, and fluid retention with pleural effusion. And what was seen in the first study is that if there was a treatment before and after dosing with steroids, it was feasible to prevent this kind of toxicity, which could be cumbersome not only from the aesthetic point of view, but also because of the potential accumulation in the pleural space. So it's important to remember. And this is the last slide, the common features of the toxicity. We mentioned already all of them. Cold cap might be used for the weekly schedules of paclitaxel only. These are the peripheral neuropathy and the bone muscle pain. Remember that it could appear from 24 hours after the administration, could last for 2 days, and paracetamol for prophylaxis could be useful. We mentioned already the fluid retention. We mentioned already the hypersensitivity reaction, and this is the characteristics of the skin toxicity with the weekly treatment. Could be onycholysis with fissuration of the nails, and also palmoplantar erythema. And the stomatitis is definitely higher with the weekly schedule, so it's important to look at the mouth of the patients. This is the last slide. So if there are comments, questions. Marcus?
There is no question from the audience. Also now not. I haven't received any question.
But were they allowed to send the question, or it was like the last time that we didn't get them because they were not able to send them?
No. I checked regularly. There is no question.
Okay. So I think the point is that if later on the audience decide to send some questions, we would be happy to answer them. And also apologize because we haven't replied yet to the ones you sent or the audience sent at the previous session. So I think it would be important for us to have a feedback to know if the session was useful, if it was understandable, if it was too long, if you have suggestions, but mostly we want to know if it's useful or not. And or if you have suggestions for doing in a different way, or if you think that other topics could be of greater relevance for your clinical practice. Okay.
Thank you, Professor Sessa, and thank you, Dr. Yorga. Ladies and gentlemen, the session has now concluded. The next ESO session will take place on the 25th of July at 6:15 p.m. and Professor Hasan Batral of the Marmara University Hospital, Istanbul, Turkey, will discuss with Dr. Luca Bertolacini of the European Institute of Oncology, Milan, Italy, the following topic: ESTS Annual Meeting, the best of. Thank you for participating, and have a pleasant evening, day, or night. Goodbye.
Bye, Marcus.
Yeah, in fact, I didn't receive any questions. I checked regularly, but
Well, yeah, I think it's great.
for attendees, but no questions.
Okay. So perhaps we could ask Francesca whether, because the other time they said they were not able. But really, I want to know if it's something useful or, how many